Hello and welcome to the fourth Tracking and Measuring the Opioid Epidemic as a Prevention Tool webinar series. Again, the series is being brought to you by a collaborative effort between the Division of Public Health Injury and Violence Prevention Branch and the UNC Injury and Prevention Research Center, IPRIC. It's also an extension of the past summer's North Carolina Overdose Summit, and specifically the Opioid and Prescription Drug Abuse Advisory Council, or OPDAC. And of course, many other partners who've contributed to this work. I'm Scott Preschel-Bell. I'm an epidemiologist at the Division of Public Health within the Injury and Violence Prevention Branch. I oversee several CDC grants, one on the Violent Death Reporting System, two others that are more specific to overdose, the North Carolina Prescription Drug Overdose Project, and a newly awarded Enhanced State Opioid Overdose Surveillance, or ESOS grant. Again, all CDC cooperative agreements. I'll be moderating today's discussion. This webinar came about as a direct result of our Overdose Summit in June as a follow-up to the data session where we had several partners and panelists discussing how and who uses what data in our state. Because we had so many great subject matter experts with very little time, we decided that we would host a series of webinars so that partners could have extended time so that they could provide additional details around their data source or system. Today, we're pleased to have State Epidemiologist Zack Moore from the North Carolina Division of Public Health and Anna Dulaney from the Carolina Poison Center. Dr. Moore began his work in North Carolina as an EIS officer from CDC. He served as a medical epidemiologist from 2008 until accepting a position as the State Epidemiologist and Chief of the Epidemiological Section in 2017. Dr. Dulaney is a clinical coordinator at the Carolina Poison Center and a pharmacist with the Clinical Toxicology Service at the Carolina Medical Center. She has been involved in drug overdose prevention efforts for many years. Today's webinar will be about an hour long. We'll have about 5 minutes or so between each presenter to answer questions. We encourage viewers to submit questions as they come up in the Q&A box or the chat box, which can frequently be found at the top of your screen, but it can be found in lots of different places. Just look for the icon Q&A or the chat box icon. Phone lines will not be open for audio questions. We also, again, encourage you to chat amongst each other and contribute to the conversation with the chat box. Again, these can be found in various points within the software, but look for those icons. Again, this is the fourth of a series of data webinars scheduled to occur on the third Thursday of each month from noon to 1 Eastern Standard Time in 2017. To find out more information about our presenters or future webinar topics, please visit the website listed in the chat box. We will be recording and archiving this webinar. Please check your inbox later for an email with a link. Past presentations should be made available as well. We're also going to be conducting a survey in the very near future to kind of assess whether or not these presentations have been a good fit for the audiences that we've had, and whether or not there's some additional information that is that you all would like to see. We've had an incredibly great attendance so far with a lot of these webinars, and we hope to continue that, but we're going to need your help for future topics and future ways in which we can make presentations. So without further delay, let me turn it over to Dr. Moore.
Okay, thanks, Scott. Can everybody see my slides and hear me okay? Assume so.
I can hear you okay. I'm not seeing your slide set yet.
Okay. Let me try it one more time. How about now?
We can see it. Thanks, Zach.
Okay, great. Sorry about that. Second time's a charm. So thanks to Scott and team, and to the UNC team also for the opportunity to talk to everyone today. So I'm going to cover data regarding infectious outcomes from the opioid epidemic. So maybe a slightly different aspect of the opioid crisis than has been discussed earlier. Talk about some of the data sources that we have, and also some of the ways that we've used the data to target our response. Try it that way. Okay. So this is a list of some infections that have been associated with injection drug use. And of course, the one that's gotten the most attention and the one I'll spend most time on is hepatitis C virus. There's also in the group of bloodborne pathogens, there's hepatitis B and HIV. Also can obviously be transmitted both from sharing of injection equipment as well as through sex, and particularly issues related to drug use, such as trading sex for drugs, etc. In addition to the bloodborne pathogens, there's also a host of other potential infectious complications, and I've just listed some of them here that I'll touch on, bacterial or even potentially fungal infections, including sepsis, endocarditis, and skin and soft tissue infections. So to start off with hepatitis C, we generally consider hepatitis C as occurring in two separate epidemics at this point in time. We have on the one hand the historic epidemic, and that's chronic hepatitis C infections. And this is most prevalent in baby boomers, people born between 1945 and 1965. We don't have data on chronic hep C, or very good data on chronic hep C in North Carolina, as I'll mention in a minute, but just based on CDC prevalence estimates and population in the state, we estimate that there could be up to 150,000 or so people living with chronic hep C infection in the state, and many of those people are unaware that they're infected. So this is a somewhat dated CDC graphic that I just wanted to include in case people weren't familiar with hepatitis C to understand why we are concerned about this. Starting at the top with, for every 100 people infected, 75 to 85 will develop chronic infections. This is that historic epidemic. And among those, 60 to 70 will develop chronic liver disease, 5 to 20 will develop cirrhosis, and 1 to 5 will die from cirrhosis or from liver cancer. And data from our Central Cancer Registry in the North Carolina State Center for Health Statistics is showing that these manifestations are already occurring for some of the people, particularly in the baby boomer generation, who've been infected for many years. We've seen liver cancer rates in North Carolina have nearly doubled over the past 10 years, particularly among men. The rates are particularly high among men. They've gone from 6.7 to 11.1 per 100,000, but also doubled among women from about 2 to 4 cases per 100,000. So we are definitely seeing these late manifestations. This is one big reason why we want to get on the acute infections before these types of late outcomes can happen. So the second epidemic, and the one that's most pertinent to the opioid situation, is the emerging epidemic of acute hepatitis C. And probably, or hopefully, everyone's aware that this has been an rapidly increasing problem recently, particularly but not exclusively in younger white persons living in poorer rural communities. And this is being definitely driven by injection drug use. Okay. In terms of the data, since that's what this webinar series is about, for hepatitis C, we do have somewhat limited data. What we've had for a long time is provider reporting of acute hepatitis C through our North Carolina Electronic Disease Surveillance System, or NCEDS. We know that acute cases are vastly underreported. CDC has looked at this nationally and estimated that it's about a 14-fold underreporting because many cases are asymptomatic or don't come to attention. We've also had changes in our case definition that make it challenging to track this over time, particularly in 2016, as I'll mention in a slide or two. In terms of chronic hepatitis C, we have just made that reportable through electronic laboratory reporting into NCEDS. That just started January 1st of this year, so we don't have any data to speak of yet, but that should be helpful as we move forward. And then just one thing to mention is that we did receive our first dedicated funding for viral hepatitis surveillance recently, one of 14 states that got the surveillance grant award from CDC, which should allow us to do a more comprehensive job at looking at, first of all, increasing screening, but also looking at risk factors and epidemiologic data around hep C. So here's what we do have for acute hepatitis C, showing the North Carolina rate in green and the United States rate in blue. And you can see a very dramatic increase in North Carolina. There was, as I mentioned, a change in the case definition in 2016 so that you no longer have to have clinical symptoms if you have a recent negative a recent negative test result followed by a positive within 12 months, you can be considered acute. So that's part, but certainly not all, of the reason for this dramatic increase that we've seen recently. So we have used some other data sources to help us understand what's going on and try to predict and prevent problems with hepatitis C epidemic. This is a vulnerability assessment that we conducted, trying to look at counties that might be at risk for hepatitis C or HIV outbreaks. So we looked at several things as part of that. One was the opioid overdose rates per 10,000 from our North Carolina Detect system, which I'm sure you've heard about on this series or elsewhere. We also looked at the acute hepatitis C that I just showed from NC-EDS. Chronic hep C, I mentioned we don't have through NC-EDS, but we did get data from Medicaid, so looking at hep C infections among Medicaid beneficiaries. And then the percent white, since that seemed to be the predominant risk group for hep C at this moment in time, and percent unemployed. And we factored all those in together to identify the counties that were perceived to be at highest risk for hep C and HIV infections. And this map shows the counties that were identified through that analysis. Red indicates those were scored the highest as being at risk. And you can see clearly it's primarily out in the west, in our, particularly the Appalachian counties, but also problems in New Hanover. And then this is a map of acute hepatitis C rates by county, and you can see it matches that very nicely, not surprising since this is one of the factors that went into that vulnerability assessment, but also shows that it's not at all limited to just the western counties, but also Brunswick and some of our northeastern counties start to have seen increases. So I just want to dig a little bit into the data on hepatitis C with you. This is age distribution just for 2016 for our acute hepatitis C cases. And I don't know if you can see my pointer here, but you can see it's in the sort of 20 to 45 age range, skewing a little younger among women, but slightly older among men, but parallels pretty nicely what's been seen with the overdose data. And then looking at gender, I think this is important. There's a concept of young white men being primarily affected, and that's really not, in terms of the gender breakdown, what we've seen. It is true that both the North Carolina rates, which are in solid, and the US rates in dash have higher rates among men, but it's not a dramatic difference, and there's also been a steep increase in cases among women as well. Okay, and then also when you look at the race, it is definitely true that when you look at number of cases, whites are driving the acute hep C reports, but you can also see increases in the Black or African American population, as well as the gray at the bottom, which is American Indian, Alaskan Native. And if you look on a per population basis at the rates per 100,000 population, it's I think revealing and a different story. We've particularly had concerns about the incidence, although the numbers are small, very high incidence among American Indians. And this is, again, particularly related to the counties out in the far west where we've seen big increases. Risk factor data we don't have great risk factor data. Hopefully we can improve that. But what you can see here is the light blue line for injection drug use has been an increasing trend in acute hep C cases who are acknowledging injection drug use. And of course, many probably have that risk factor and do not acknowledge it. Okay, so that's just a quick snapshot of some of our hepatitis C data. And this is how we've used it to form our response. This is what we're calling our hep C TLC, or test, link, and cure approach. Testing means identifying and testing high-risk populations. Linking means bringing them into medical care for hepatitis C, but also linking them to mental health, substance abuse, treatment services, and social services as needed. And then cure, the sort of paradox with hepatitis C is that this is this exploding public health problem at the same time that we have these new and highly effective direct-acting antivirals where it's actually quite curable. So we're very intent on getting people into cure to obviously for their own health, but also to eliminate onward transmission and reduce the prevalence in the community, and particularly in high-risk populations. Here's some of our successes. We have increased access to Hep C testing through the state lab. We've also used some of our existing HIV infrastructure, our disease intervention specialists, to sort of work some of these networks of transmission and identify contacts and get them tested and hopefully into treatment. On the linkage front, we've been hiring hepatitis C bridge counselors, again, borrowing from our HIV experience. And these are people who work with newly identified hepatitis C infected individuals to get them into care. And we've been coordinating with syringe service programs, federally qualified health centers, local health departments, et cetera, to link people into other services. And then for cure, we quickly identified that there was a dearth of providers, particularly out west, who were willing and able to treat hepatitis C. So we launched Carolina's Hepatitis Academic Mentorship Program with experts from UNC and Duke, which has been hugely successful in getting primary care providers out in remote areas comfortable treating hepatitis C. And we've also put out some materials more broadly to help increase the number of providers who are willing to take this on. Okay, I'm just going to briefly touch on some of the other infections that have been associated with the opioid epidemic. Acute hepatitis B, you can see the rates of acute hep B again from our case-based reporting at NCEDS have increased. In the green is the North Carolina rate, which has gone up since 2013, which is concerning, also increasing nationally. And if you look at the county rates, it's fairly similar to what we've seen in acute hepatitis C in terms of distribution. Also similar in terms of the race ethnicity breakdown, where we've seen a particularly high prevalence or incidence rather, among American Indians. And also in terms of reported risks, this doesn't look very dramatic, but if you look at the gray line from 2012 to 2016, it's more than a twofold increase in the number of people with acute hepatitis B who report injection drug use as a risk factor. Okay, turning to HIV, the gray shaded area indicates HIV prevalence, which is increasing in the state, and that's not a bad thing. That's mostly driven by improved antiretroviral treatments. So we have basically the death rate is decreased, but unfortunately this light blue of line of new diagnoses has sort of plateaued around 2012, and we've seen even a slight increase in our new HIV infections, which is worrisome. Now I'm just going to sort of walk you back through 10 years real quick in terms of changes in new HIV infections, in terms of age distribution. This is going back to 2007. Males are in the light blue, and you can see sort of a even distribution in the younger age groups. As you get to 2012, you start seeing more of the cases among younger people, and up to 2015, and you can see a real marked increase in the incidence among younger populations. And this is primarily young Black men who have sex with men driving a lot of this, but not entirely. And this is HIV new diagnoses by county. And what we've seen here is it's a very different distribution and a different sort of risk group at this particular point in time. Of course, what we are concerned about is that those risk groups will overlap, and we've seen some of that already. I'm sure people are familiar with the Scott County, Indiana outbreak, which was reported as an HIV outbreak, but 90+% of those folks were also Hep C positive. So we definitely have the same situation going on here in terms of drug networks, et cetera. It's just a matter of when HIV gets introduced into those networks, hopefully we can prevent that. Okay, and finally, to wrap it up, leaving the bloodborne pathogens behind, this is some data from Aaron Fleischauer with our group and others looking at the incidence of drug-associated endocarditis among hospital discharges over the past few years. And you can see going back from 2010 to 2015, a dramatic increase, in any emergency department or infectious disease clinicians will tell you this is their lived experiences, that the number of acute endocarditis cases has skyrocketed, particularly among the younger age groups, 18 to 25 and 26 to 40. It's become a much more frequent occurrence. And in terms of morbidity and cost, it's a huge problem. These green bars represent hospital costs by year for drug-associated endocarditis, and the blue line represents the percent increase. You can see more than 18-fold increase in hospital costs for this complication of drug use. Okay, and I'm just going to end with this slide, which I think was probably stolen from Scott many years ago and tortured, but just to point out that these are all sort of overlapping things. If we're talking about overdose, we're talking about Hep C, HIV, you could throw in hepatitis B. You know, there's many specific things that can be done, but it's important for us also to focus on the overlap and things that can be done to address all of these problems, including access to mental health and substance abuse services, targeted screening and referrals, and comprehensive programs to reduce transmission and to address stigma and disparities. And I would include syringe service programs in this category. With that, I will wrap it up, and maybe I will even stop sharing and open it up for any questions.
Is the data on liver cancer rates for all etiologies or specific to hepatitis C?
That is for all etiologies. So we believe that that's driven by the big bolus of people with chronic hepatitis C that are sort of aging into those complications from the baby boomers, but that's not specific. It's not limited by etiology.
Sure, great, thanks. So another more logistical question just for folks. We are recording this presentation, so it will be made available. If you're asking specifically for slides, you can certainly contact the presenters, and probably most of them would share some of those slides, and you could then use them again in various settings. But, you know, reach out to the presenters specifically for that. And, you know, there's obviously usually caveats around certain slides and data and how they're presented. So make sure you understand if you are asking for the actual slides to in a PowerPoint kind of mode, that you also understand the nuances around using those data. Let me ask another quick question. And again, I'm going to encourage folks to, you know, you go ahead and use the chat box or the Q&A for questions. But what would it take to kind of identify all hepatitis cases and kind of get them treated? I mean, you know, what's the process with that? And, you know, clearly there's new treatment medications available, and as you mentioned, they're incredibly effective. And I guess what I'm interested in that is, obviously you showed with some things kind of an increased cost, and there would be, with getting them, you know, linked up with treatment, there would be an immediate kind of cost, but then there'd be hopefully a lot of future, you know, along with kind of health benefits, but future healthcare savings down the road. Can you talk about that a little bit?
Sure, and I think it really is kind of two separate but obviously related issues in terms of screening and how you identify people with hepatitis C and then how you get them into treatment. I think there's been some hesitation to even test for hepatitis C because there's this idea that, well, first there was the idea that it was untreatable, or that, you know, because we had these very difficult to take and not very successful treatments, and that's changed. So, but now there's this perception that it's cost prohibitive and that there won't be any way of getting people treated, so why bother? So trying to increase screening, part of that is overcoming that barrier, because first of all, even if someone doesn't have immediate access to treatment or doesn't want treatment, there's other reasons why it's good for them to know their status. There's other liver protection things they can do, vaccination against Hep A and Hep B, counseling on things to protect their liver health, et cetera, counseling on transmission. So there's lots of reasons to be screened, even if treatment is not immediately an option. And we're trying to accomplish that in a lot of different ways. And I won't get into all of them, but there's lots of different efforts to identify sort of high-risk populations and increase screening in those groups. That includes a new project that's just launching now with RTI out in those western counties. But then increasing access to treatment is the second part of that, and that's definitely a big focus. And I think there's good news in that regard. It seems like things are improving from a cost perspective, and I know our Medicaid program is looking to reduce some of the barriers to treatment in terms of requiring certain levels of fibrosis, et cetera. We've been trying to reduce the barriers with this CHAMP, the Hepatitis Academic Mentorship Program, et cetera. So it's not really a one answer, but there's sort of a lot of efforts along those lines underway.
Great, thanks. And just one last one. We're not seeing any posted at the moment, but you had the slide up about Scott County, Indiana, and obviously that was a couple years back now. But how do you think it changed kind of the way we were working in North Carolina in terms of, again, kind of more to your last slide about how these things kind of are coexisting or endemic and synergenic, with these outbreaks?
Well, I think in a couple ways. I mean, it got people's attention, but it also did show how much overlap there is. And most of our hepatitis program here has been built with no actual dedicated funding, and we've taken a lot of our HIV resources and tried to use those that infrastructure and those lessons from years of dealing with HIV to bring it to bear on the hepatitis C epidemic also, because there is so much overlap there. I think, problem I have with Scott County is, people are always talking about how we don't want a Scott County. And in many ways, we do already have that situation. We do have those intense, multi-generational, high frequency injection networks already. So it's that part of it, it's already out there. And so I think our big goal is to try to address all these different things before we end up in a situation where we have people with HIV introduced into that kind of network, and it's just sort of, lighting a match to the tinder.
Yeah, that's great. So here's another question coming in. Many IV drug users in our area report not wanting to know, in quotes, their status, predominantly HIV. Have you identified any effective stigma-reducing programs or messaging to increase the number of folks that seek out testing?
Yes, and I would say, of course, the North Carolina Harm Reduction Coalition has been a real leader along those lines. But we've heard the same thing, that people either take sort of a fatalistic approach, or they don't see it as an acute problem that's, it's not high on their list of priorities, even if they find out that they're Hep C infected. And I think there have been a lot of, I couldn't really list you sort of chapter and verse what's the data on successful outreach or educational campaigns, but I think a lot of it does have to do with, I think it was in the question, about addressing stigma and helping people understand both that this is a treatable condition, a curable condition, unlike HIV, and also what this can mean in terms of not spreading the infection to other people in your community. I think those are messages that have been put out there a lot more eloquently than I just did, and I think, again, the Harm Reduction Coalition's got a lot of good materials along those lines.
Yeah, that's great. Thanks, Zach. I appreciate you presenting today, and it's a great kind of plug for the Harm Reduction Coalition in our state. They've done a lot of work in this space and continue to do some of that work. And of course, last year, you know, a needle exchange law came into effect. We were the first southern state, and so there's about 25 or so counties where they have the actual physical site, but of course they're working with multiple counties, and also people are coming from various jurisdictions in for that. And so hopefully we'll see some changes in some of these trajectories, and I appreciate all the hard work you guys do to work on this. And again, for those of you who are interested, you know, the Epi section does a number of really great detailed reports, and you can certainly refer to some of those, you know, when you get a chance. Let's go ahead and turn things over to Dr. Dulaney from the Carolina Poison Center, and have her present for a few minutes. And again, reminder to the attendees, you know, please post questions in the chat box or in the Q&A, and we'll kind of handle them as at the end of the presentation, but we don't want to forget about questions either. Okay, Anna, go ahead and take it away.
Okay, are you seeing the correct screen? Let's make sure.
Yep, looks good on my end.
Okay, all right. Well, thanks again, Scott. I'm Anna Dulaney. I'm with the Carolinas Poison Center, and want to talk a little bit about who we are and what we do, and how we, what we are doing as part of the opioid crisis, and how we can move forward with prevention efforts in the future. So we are the designated poison control center for North Carolina, and we're certified nationally, and we have been since 1995. And we're an emergency call center, and so data is kind of something that comes after treating patients. But we do answer the phones 24/7. We never close, and our phones are answered all the time by registered nurses and pharmacists with specially trained in toxicology, and we call them specialists in poison information, or SPIs. A lot of people think that poison center folks are volunteers or something other than that, but no, our staff are very well trained individuals. They are backed up all the time by board certified toxicologists. We have 4 medical toxicologists, and I'm a board certified non-physician clinical toxicologist, and one of us is on call 24/7 to either talk directly with providers or back up our staff if they have questions. And then we have training programs for both physicians and pharmacists who want to specialize in toxicology. Now, where our data comes from is that all cases are entered into a database we call Toxicol, that it serves as both the legal medical record, which is in free text, and then some data points that we do collect that are blinded. And the blinded data is what is uploaded into NC Detect to make up part of that database, and the National Poison Data System, which all poison centers send their data to, or NPDS. And that happens to NPDS at least about every 5 minutes. So it's pretty rapid. So what do? Well, we handle just about anything a human can come in contact with by triage and treating human poisoning exposures or overdoses. We are not an animal poison center, but we answer questions about animal exposures if we have them. And we do a lot of informational and prevention calls. For instance, right now we do a lot of pill identification for law enforcement. And then we do a lot of, you know, how do I keep my home safe? How do I talk to my children about drug use, etc., and other non-opioid related prevention calls. And again, the types of substances we can get called about include, again, anything on the planet that a human can come in contact with, whether that's envenomations, whether that's plants and mushrooms, or other things around the house. But a lot more of our exposures than anything else are made up of over-the-counter and prescription drugs, herbals, supplements, cultural medications from other countries, and illicit substances as well. And that can be, the drug calls can be anything from intentional overdose, as in suicide, or in substance abuse and misuse, or even dosing errors. Medication, the wrong medication at the wrong patient, or the wrong dose for a patient. All of those are things that we handle 24/7. So one of the things that the opioid epidemic kind of also parallels is the fact that calls to the poison center are not just about by moms who were calling about their children getting into something. And when we first opened 25 years ago, that was most of our calls were calls about babies getting into things. Well, a couple of things have happened. One, the birth rate in the United States has gone down. And secondly, the advantage or the advance of the internet has allowed people access to some of the more simpler exposures and how to handle them, and when you don't really need to call the poison center. And what we're seeing nationwide, even though call volume is down nationwide for some of those same reasons, and again, the internet and the birth rate being down, is calls from healthcare providers and healthcare facilities are increasing all across the country. And this is a schematic from the 2015 NPDS report that shows that continued trajectory of calls from providers. And what comes with that are more complicated cases. So it's not just things that are simple, oh, your child ate something that is non-toxic. If you just clean out the mouth, they'll be fine. But to physicians and first responders and nurses and pharmacists and PAs calling us from an emergency department saying, this is what I've got, tell me how to treat this, or I don't know what this is, can you help me figure it out? And again, this is just in tabular form, that in 2015, over 22% of our calls came from healthcare facilities. And again, a lot of that has to do with what we're seeing in the opioid crisis. Now, what about in North Carolina? I went back as far as 2011, which is the first year that we had new specific opioid product codes in our database. And so that's why I'm comparing either from 2011 on or just 2011 in this past calendar year. Well, even though we had more calls in 2011, under 25% were from healthcare facilities. And less than 10% of those cases were what we would say are sicker patients. They have moderate severe outcomes or death. As opposed to last year, again, even though we had fewer calls coming in, almost 30% are from healthcare providers, and 11% of those cases result in moderate to severe outcomes or death. And that's something that, again, we're all seeing nationwide. Even though our calls are down, our staff are busier and they're handling much more complicated cases. So let's look specifically at opioids. And human opioid exposures, if you look at our total numbers across the bottom there, that's kind of paralleled our total call volume, but over the last couple of years, from 2014, you see an increased number of exposures. Now, while adults have remained fairly steady, we're seeing some changes with our adolescents and younger children. Now, 6 to 12-year-olds are always going to be our lowest number of cases, regardless of the substance, because those are children that can read, can discern right from wrong, and are usually your rule followers before they start experimenting in the adolescent years. But the most concerning figure here is actually last year, the pediatric numbers of children getting into or being exposed to opioids has climbed quite a bit, and that's a little concerning. And again, our adolescent numbers are starting to go back up as well. Now, when you break down adults, and this is cases with ages reported, every year there's about 1,500 to 2,000 cases where either the patient or the caller refuses to give the adult's age. So those cases are not included, but when we're given the age, again, the 20s to 40s, and some of this actually kind of parallels some of what Zach's slide showed earlier, is that increased risk when you're younger adult years. But what's concerning now is to start looking at the 20s and 30s and 40s numbers are relatively steady across the board. But last year, we saw big increases in our patients in the 50-year age group, as well as our 80-plus year age group. And that might be a factor of finally seeing the results of increased prescribing over the last decade or so of opioids to older patients. Most frequently reported substances, what's interesting is the top 4 have remained the same. acetaminophen and hydrocodone, which is better known as Lortab or Vicodin. Acetaminophen and oxycodone, brand names would be Percocet or Roxicet, being the top two for years. And that's because they're also the most commonly prescribed opioids. Tramadol, even though technically it's not an opioid, we include it because of how it behaves in the human body. And oxycodone, again, those top four have stayed the same over the last few years. However, if you look at last year, the growth of heroin use and buprenorphine availability have bumped those two into the top six, whereas we rarely get calls about morphine these days as we did back in 2011. And in fact, after this top six in both years represented here, there's a big drop off in the other substances that were called about. The other thing that we're seeing is we are seeing an increase in naloxone use. And again, that's not always reported to us. If a patient gets to the hospital and they get naloxone prior to arrival, we're not always told that, so we're not always capturing that. But we are again seeing an increase in naloxone use to kind of parallel the increase in heroin and buprenorphine. Fatalities, even though the last couple of years our exposures are going up to opioids, fortunately our fatalities have remained fairly steady. Again, when you look at the pediatric data, we have had 3 pediatric deaths reported to us in the last few years, and all 3 of these children were 2-year-olds who apparently got into an opioid in the home where they were being watched or cared for. But again, fortunately, our fatality numbers have stayed relatively steady, again, that were reported to us. So what are some of the limitations of our data and what we can do? One of the things is that poisonings are often underreported. It's a lot of data sources say that about 50% of all poisonings and overdoses are not called into Carolinas or to poison centers in general. And that's probably true, although again, we're seeing an increase in calls about severe cases. Most ED providers can handle what we call, quote, standard heroin without assistance, and so they don't call those in. So those numbers are underrepresented here. And we don't get called about patients that are already deceased and found dead, because again, we're called for assistance in treating the living patient. Community and first responder naloxone rescues are usually not included in our data set unless someone calls them in. And then as well trained as our staff is, apparently sometimes we do have some issues with naloxone use that may be charted in the free text but not documented in our separate data set. And right now our cases, our data system does not allow us to search the free text fields for words like naloxone. And the other thing, when we're looking at exposures by county, the county recorded is the county where the call came from. And so if the patient is already at a healthcare facility, that's where the patient is being treated, but may not necessarily be where the exposure occurred, because some patients are transported into a neighboring county for care. One issue we often get asked about is ethnicity, and ethnicity is not part of our data set. It's not something we routinely collect. However, we do collect gender and age, and we can search by age range according to predefined American Association of Poison Control Center definitions for age ranges. And manpower, building and running searches to look specifically and drill down at specific substances in county. As with a lot of us on these webinars, we all wish we had more people to do the things that we want to do. And the time to do the more things we want to do. I'll get back to that in a second. Substances, when we are called about an exposure, the substance documented is what it's suspected of being if it is not positively identified, and we don't always have a positive identification on the substance. One of the things that we run into that a lot of lay people are unaware of is that the standard urine drug screen in the emergency department is extremely limited. That will pick up heroin, codeine, or morphine and show positive as an opioid in most cases. Some of the semi-synthetic agents like hydrocodone and oxycodone may or may not show up unless they're present in large quantity. And drugs like fentanyl and methadone and some of the fentanyl and all the fentanyl derivatives will not show on a standard urine drug screen. Some facilities have added substances like oxycodone or methadone to their standard screen, but for the most part, we can't identify an opioid by a simple urine drug screen. And send-out screens are costly, and it will be several weeks before results come back. And quite frankly, usually we don't use those results to guide our treatment recommendations. We treat what we're told about or what we see in front of us. Another issue with substances is NPDES product codes for new substances. There's a little bit of a delay in getting that information so that we could code a fentanyl derivative in our data set as a fentanyl derivative. That takes about 6 months minimum before we can get that into the data set. We are going to be able to go back and recode substances automatically without having to go manually redo it starting in 2018. So we're looking forward to that. Medical examiner information is great from the lab because it is analytical, positive identification of substances. But again, that's not something that we often have in order to help us treat live patients. And we're often not aware of what's on the street in real time, which limits our ability to educate the provider on the other end of the phone and to tailor our recommendations to the specific patient we're being called about. But what about some opportunities that we see and things that we can do moving forward? Well, as we all know, there's not enough providers in North Carolina that can address addiction. And actually, one of our medical toxicologists and both of our medical fellows are now certified to prescribe buprenorphine because of the need. And the same medical toxicologist will be sitting for her addiction medicine boards next month because at our parent institution, we don't have enough people who can treat these. And a lot of treatment of or attention to the addicted patient has fallen to us because for a long time there wasn't anybody else who could do that. We are encouraging naloxone dispensing and use, and again, our nurses and pharmacists that answer the phones are trained in instructing how to use naloxone over the phone and could easily walk anybody through it, and then also can follow up for outcome if the patient needs to go for treatment at the emergency department. We can follow up and make sure that happens. Excuse me. And the other thing we'd like to be doing is working more closely with labs and law enforcement to know what's out there so that we can tailor provider education and patient treatment, and also to quell the rumors and the misinformation, which there's a lot of that out there. An example is we'll get a phone call saying, you know, I've got a patient that may have used gray death. And we'll say, well, how do you know that it's that? Well, that's what has been on the news and that's what this might be. And so a lot of time is wasted when we could be caring better for the patient if we knew exactly what was going on and not just people responding to rumors and not having the exact information of what's out there. Other things are our toxicologists and our poison specialists can answer questions. We provide poisoning management recommendations. We can give lectures in different regions to different providers. And we can share the position statement that the toxicology community in general put out recently on workforce exposure to opioids by healthcare providers. I am working on getting some automated data runs to put on our website on a frequent basis. However, that's still a work in progress. Stay tuned for that. But anytime you have any questions, you can give us a call. Our website address is there. You can order our prevention materials, which we have our Sharing Pills Can Kill that addresses teen substance use. We've also got materials for parents, for babysitters, for senior citizens, and avoiding medication errors. And it's all easily accessible from our website. You can go to our store on our website. And I think that's it. And I'll take any questions if you have them.
Thanks, Anna. This is Scott. So we do have a couple of questions. Let me go ahead and tell you what they are. The first one's coming from Roxana. It says, what's your definition of exposure?
A definition of an exposure is a human coming in contact with a substance by any route.
Okay, and then the next question is on the slide that reports the top drugs that you receive calls about, would the buprenorphine represent only the single ingredient buprenorphine products, or would it include combination products like Suboxone?
It would include the combination products. I'm unable to easily tease that out. I can tease that out by looking at the specific products, but I did not do that for this presentation. But that number that you see, or the fact that it's in the top 6, reflects that that includes both the buprenorphine naloxone and buprenorphine alone. Great question.
Great, thank you. Yeah. So I have another quick follow-up question. This is coming from me, and again, I'll remind the attendees if they can jot questions in as well. You know, there have been a lot of conversations about kind of occupational exposure, and I know that the poison control centers and toxicologists across the nations have kind of put out the position statement, but kind of in a nutshell, you know, what's kind of the gist from that position statement from that community?
Powdered fentanyl and the powdered fentanyl derivatives are not well absorbed through the skin, and I think that was one of the biggest concerns. And basically, with most substances, the newer synthetic fentanyl derivatives, etc., standard precautions by first responders and by healthcare providers is all that is necessary. Your gloves, your gowns, your face shields that you would normally use in taking care of patients. Actually, what's coming out is that the bigger concerns may be with canines, because they are, you know, they are more exposed to powders and are more likely to inhale at close range some of these substances and are more likely to be affected than humans are. But basically, the information is that standard precautions that we all take at the bedside or in the ambulance is usually all that's needed for humans and people taking care of or being close to these substances. And that's a joint position statement from the American Association of Poison Control Centers, the American Academy of Clinical Toxicology, and the European and Asian Academies of Clinical Toxicology.
Yeah, thank you for that, because again, we've certainly heard lots and lots of feedback from first responders in particular, and again, I think the media in this particular case, you know, has exacerbated some of those risks potentially. I mean, there clearly are risks, but they're pretty low, and again, universal precautions for most people, and again, particularly for dermal exposure. Obviously, if it's aerosolized or if you're breathing it in, there's some other risks associated with that. But hopefully, most people who are just working with, you know, community members in general and people who are overdosing are probably not, you know, gonna risk overdosing from that encounter, and they're probably much more likely to need naloxone for that person who's on the ground than themselves doing that work.
Absolutely, totally agree.
Yeah. And again, there's a lot of interest. The Attorney General's office in particular, and I know some law enforcement agencies have kind of asked for, you know, a fact sheet of some sort and type. And I know that the Poison Control Center, along with the Division of Public Health, has been working on something that hopefully folks can utilize out there and for that measure. We're getting a little bit close, but let me ask one other quick question. I don't see anything posted at the moment, but you know, for the fentanyl analogs in particular, I'm assuming a lot of healthcare folks are calling and such. I mean, is treatment modality all that different, or talk a little bit about like what happens in terms of treatment, whether it's fentanyl versus any other opioid?
Great question. You know, as I said, people usually don't call us about just what I call standard heroin, because heroin, when it's just heroin, usually requires only small doses of naloxone in the chronic user, because you don't want to put somebody in withdrawal, and so we give very small doses. When we realize that it's likely something other than heroin, And our current knowledge is that what we're seeing mostly in North Carolina is that isn't heroin, is fentanyl, and not some of the fentanyl derivatives, although they have been found, is that it requires much more naloxone than we normally would give with heroin. For instance, a chronic user that is known that comes in the door needing some naloxone that may have just overdid a little bit, they might need like 0.1, 0.2, 0.4 milligrams of naloxone, enough to keep their respiratory drive going. Whereas when somebody calls and says, we just have a patient that supposedly used heroin, but it took 6 milligrams of intravenous naloxone to restore their respiratory drive, then that's a clue that it's probably not just heroin, because having to do with how naloxone binds at the receptors and the different drugs bind at receptors, we know that we need higher doses, and that's our first clue that it's something other than heroin. And so then also the next question comes, do we watch this person as long as we do a heroin, or do we need to watch them longer? And with some of the synthetics, we don't know the answer to that yet, because we just haven't seen enough of them. And so we're tending to recommend a little bit of a longer observation time, just because we don't know what the patient used, and we don't know if they're going to, if whatever they used is going to last longer than the effects of the naloxone.
Great, thank you so much for that. I'm not seeing any other questions in the queue, but again, I would recommend for folks who have additional questions, you can always usually reach out to the presenters themselves or to us, and we can certainly try to triage some of those questions if you come up with them later. Again, thank you, both Zack and Anna, for great presentations. And again, I want to mention that the Carolina Poison Control Center is a great resource for our state, and we should take more advantage of it, and particularly for the work that we're doing at the moment around opioids. So let me end briefly with a couple of quick notes. Again, I want to thank everyone for attending the 4th webinar in this series around tracking and measuring the opioid epidemic as a prevention tool. I want to remind you that this webinar has been recorded and will be made available to you or others after this date. Past webinars will be posted as well. So, feel free, once it is circulated, to, put it through your networks or others, and then they can benefit from these presentations as well. I hope that you all will join us next month on November 16th on the 3rd Thursday from noon to 1. The November webinar will feature Dr. Ruth Winokur, who's the Chief Toxicologist from the North Carolina Office of the Chief Medical Examiner. We're currently not planning to have a December webinar, but we're happy to change that if someone makes some suggestions or anything else. We realize December can be a challenging month in terms of other things going on. And we will be seeking your help to see if these webinars have been valuable and whether we should plan and schedule them into 2018. So we will be doing kind of a quick assessment or webinar. Again, that will be kind of circulated in the near future. If you want to find out about this or any other presentations, again, visit the webinar opioid link that's being posted in the chat box now. I want to thank you all for being here today and for all the work you do to prevent overdoses in North Carolina. And with that, we'll end today's webinar. Thank you so much.